WHO analgesic ladder, step 1 and step 2 drugs. So all of you all are nurses, or are there any doctors also in this group?
Nurses only, ma'am.
Nurses only. And are they all from, I see a couple of them from Nepal. Which other places are they from other than India?
We have people from India, Nepal, and Ghana.
Ghana. Okay, that's very nice. Okay, it's sharp 3 o'clock. I hope to finish this class within 40 minutes. Is that okay? 45 minutes?
Yes, ma'am. Yes, ma'am. That's fine.
So now can I have the first slide, please?
Yes, ma'am. Sure.
Okay.
Is it visible, ma'am?
Pardon me?
Ma'am, is it visible?
Yeah. I want to see the full screen. Wait on 1 minute. Okay. Right. So can I have the next slide, please? Okay. The next one. So I'll be talking about pain management in cancer, and the broad outline of my talk would be, I will talk about the basics of the WHO analgesic ladder. What is this WHO analgesic ladder? All of us need to be familiar with it. And I will be focusing on step 1 and step 2 drugs of the WHO analgesic ladder. But I will also discuss the adjuvant drugs that are given along with it, which includes drugs for neuropathic pain. Okay, next please. Am I audible to everybody?
Yes, ma'am, you are audible.
Yes, ma'am.
Okay. So before we go on to the drugs, let us see the role of pain management in cancer. In Montreal, Canada, there was an international summit of pain physicians. That is the Indian Association for Study of Pain, IASP. It was in 2010. And they passed a declaration that access to pain management is a fundamental human right. Now, we all have fundamental rights, right? Right to speak, right to religion, right to vote. All these are our fundamental right to health is a fundamental human right. They also said right to pain management is also a fundamental human right, and everyone needs to be adequately assessed and treated by pain by trained healthcare professionals. Next, please. So, according to the international human rights law, all countries have to provide pain management medications as part of their core obligations under the right to health. Like I said, we have a right to health, and even pain is also, management is also a right. And in case it is not given, and the people are having pain and they have to suffer in pain, it is a violation of this obligation, and it is termed cruel, inhuman, and degrading. That are very harsh words, but that is how, if you don't provide pain management, it is considered as bad as cruel. Now, cancer pain is also now become a big healthcare priority, and the World Health Organization has developed policies and strategies to treat it with an emphasis on total pain management. I think all of you are aware what total pain management is, right? You might have had the introductory class, right? So that you might have known about what is total pain management, what is right. Okay, good. Okay, next, please. Now let's come to the WHO analgesic ladder. Next. Now this ladder was devised in 1986, more than 30 years ago. And it was based on the recommendations of a group of international experts who met and formulated this ladder. And after that, it has been translated into 22 languages all over the world and used to treat cancer pain everywhere, all across the world. Next, please. Now, this is a very simple, it's a well-validated tool, and it's an effective tool. Well-validated means it has been proved to be effective. So that is what is meant by well-validated. And it is a stepwise approach to the treating cancer pain depending on the severity of the pain. Now, before the WHO ladder, people were dying in unnecessary pain because of cancer. And why was that? Because opioids, there was a big regulation, drug regulation to administering opioids. And as a result, it was not freely available, and there were a lot of restrictions. And as a result, people were trying to avoid using opioids, you see. And also, giving opioids and taking opioids was considered stigma. That means they are on drugs, they are addicts, and that kind of stigma was associated with morphine, drugs like morphine. So as a result, people were avoiding taking the morphine. But because the WHO has endorsed this WHO ladder, in which the third step is actually giving opioids like morphine, and since it was recommended by WHO, this now became legitimized. That means people all over the world could say that we can give morphine when people were not afraid to take morphine. So it legitimized the use of opioids. As a result, unnecessary pain and suffering could be avoided. Next, please. So when you want to apply the ladder, it is, I said, based on the severity of pain. So we all need to know what is the intensity of pain the patient is having. That is number one. You must know the severity of pain, because only then you can apply the ladder. Secondly, we should know whether is the pain nociceptive or neuropathic. Do you know the difference between nociceptive and neuropathic? Yes. Uh, I can't see everybody by the side. Let me see how I can do that. Oh, yes, got it. Do you know? Yes, okay. Because that was also part of your introductory class, I think. So, because if you know it's nociceptive and neuropathy, you will know which drug to give. Okay. And also, like I said, is the pain mild, moderate, or severe? So for that, we have various scales, like the visual analog scale or the numerical rating score, which is called the NRS. So based on that, we can assess the severity of pain and then apply the ladder. Okay, next, please. So this is a WHO analgesic ladder. You see, there are 3 steps: step 1, step 2, step 3. Now, step 1 is when there is mild pain. That means the NRS is just around, say, maximum 2 to 4 or something like that. Now, in that kind of pain, what is a drug that you give? You give a non-opioid analgesic drug, right? Non-opioid is something like a paracetamol or a non-steroidal anti-inflammatory drug. But that can be combined with an adjuvant drug. Now, adjuvant drugs, I will talk about it later on at the end of my class, but they are drugs that are given along with the analgesic drugs because they also have analgesic properties. But they're used to treat specific types of pain, which may be either neuropathic or abdominal pain or headache or something like that, right? So, in step 1, you give a non-opioid analgesic with or without an adjuvant, depending upon whether those kinds of pain are there. Okay. Now, if the pain is not responding to step 1, or if the pain is moderate, around, say, maybe around 5 to 7, then you can go up this ladder and go to the next step, which is a step 2, which is a weak opioid. Again, you can combine a non-opioid analgesic like paracetamol, or you can even combine an adjuvant. So you may have to give even 3 drugs. That is a weak opioid, a non-opioid, and an adjuvant. So this is the step 2. Okay. Now, if the patient is not responding, that is, the pain is not coming down, even with step 2 drugs, then we go to the next step, which is step 3. Now, step 3 is when the pain is very severe. That means it can be anywhere between 7 to 10. Okay. And in such cases, then instead of a weak opioid, you give a strong opioid like morphine or methadone or something. But again, you can combine it with the paracetamol or an NSAIDs. And also you can add an adjuvant drug depending upon whether the other kind of pain is also there, like a nociceptive pain or, I mean, neuropathic pain is there or not. So this is how we go up the drug. But sometimes you don't necessarily have to go like 1, 2, 3. After 1, if you find the pain is very severe, then you can go straight to step 3 also. You can even skip the second step. Or if the pain is coming in very severe pain in the beginning itself, you can start giving the step 3 drugs also. But ideally, we should go up the ladder. Okay. Now, using this ladder, that means up to step 1, step 2, step 3, 71 to 76% of cancer pain can get satisfactory relief. That means even the strongest pain can get relieved. So that is the advantage of the STEP WHO ladder. Next, please. So what are the salient features of this ladder? Okay. Now, the first and foremost, you just remember three things: by mouth, by ladder, by clock. That means all the drugs are given by the mouth, by the ladder, or by the clock. The others I will also talk, but these are the three very important features of the WHO ladder. What do you mean by mouth? That means the oral route is the standard route of administering these drugs. Okay. For example, paracetamol or NSAIDs or anything is all administered by mouth. Now, because of that, it's a big advantage. That means the patient can take it himself or herself, or the attendant can give, that is, a caregiver can give the drug, or the visiting nurse can visit at home and give the medicine. You don't need to give it intravenously, subcutaneously, or intramuscularly. It can be given by the mouth. So this is very well suited for home care. Okay. Now, the second important feature of the WHO ladder is it's given by the ladder. As I mentioned earlier, you go up the ladder, step 1, and then step 2, and step 3. So it is usually, in most cases, you can go up the ladder depending upon the pain. The next important feature of the ladder is that it is given by the clock. By the clock means you give it according to the duration of action of that medicine. For example, we know that the action of paracetamol is for 6 hours. So when you give paracetamol, at the end of 6 hours, you must give the next dose of paracetamol. Or you want to give morphine. Now, the duration of action of short-acting morphine is only 4 hours. That means every 4 hours you have to give. So if you tell that the medicine is given at 6 in the morning, the next dose of morphine has to be given at 10 in the morning. That is after 6 hours. So you have to tell the patient, don't wait for the pain to come back to take the medicine, but take it according to the time on your clock. And that varies depending on various drugs. It's different for Voveron or diclofenac. It's different for paracetamol. It's different for morphine. So based on the duration of action of the drug, you have to give the medicine, right? But also sometimes there could be a breakthrough pain. Breakthrough means if you're given morphine and in between 4 hours the pain is happening, then you can also advise them what to do, how to handle that breakthrough pain. Okay. Another characteristic of this WHO ladder is it's individualized to the patient. That means the right dose for that person is the one that is relieving the pain of that patient. For example, one patient can get relief with, say, about 24 milligrams of morphine. He's getting good relief. But another patient is getting relief with 60 milligrams morphine. So, but the actual thing is, the patient should have pain relief. That is the most important thing. So it all depends upon the patient and the severity of pain. Secondly, also, if you have to explain that you have to, when there's a breakthrough pain, this is what you should do. And you must, explain all these to each and every patient. It can vary from patient to patient. There is no standard dose for all patients. Each patient can have a different dose. And that dose is the one that is actually relieving the pain completely. Okay. The fourth important characteristic is that with this ladder, you use adjuvant drugs, which I will talk about later, depending on the other kinds of pain that are present. And then also we have to pay attention to detail. That means we should take into consideration the patient's age, the patient's body weight, whether he's emaciated, whether he's obese, whether he has got other diseases like heart disease or lung disease or asthma, or does he have a kidney problem or gastric problem. So all that has to be taken into consideration when you're giving the drugs. So you have to pay attention to every detail of the patient. So that is all about the salient features of the WHO ladder. Am I clear? Have you understood what I'm trying to say? Yes? Okay.
Yes, ma'am.
Okay, fine. So what are the advantages of the WHO ladder? See, now what I told you, isn't it simple and it's easily understandable. So that is very important. Yes. Okay, thanks. Then, like I said, it's a very effective tool. It has been proven to be effective. Another important thing is it's very cost effective. That means it is not expensive. These drugs that we are giving, like paracetamol, NSAIDs, morphine, they are not expensive drugs. So cost is not a problem. Second, the important thing is it can be given across the world, even in the low income countries. Also, you can give this WHO ladder drugs. It's very easy to give it, provided it is explained properly to the patient. Like I said, it's well suited for home care because all the drugs are given by the mouth. Only instructions have to be given to everyone. And also, you can even give it in other non-cancer chronic pain or even in acute pain also. So these are all the advantages of the WHO analgesic ladder. Next, please. Now, like I said, you have the step 1, step 2, step 3. Here, I'll just show you. In step 1, you give a non-opioid with or without adjuvant. In step 2, you give a weak opioid with or without a non-opioid, that is like a paracetamol, and with or without adjuvant. And in step 3, you have to give a strong opioid with or without a non-opioid. Normally, we have to give a non-opioid and with or without an adjuvant drug. So you see, in all the steps, you can use a non-opioid drug. Adjuvants can be used in most of the steps, depending on whether the patient has the other kind of pain also. So this is how we can treat cancer pain. And opioids are not are only necessary to treat the most severe pain, that is in step 3. Next, please. So sometimes you need to modify the analgesic ladder. Like I said, sometimes you can go straight from step 2 to step 3. Or if the pain is even not responding to step 3, then you may have to add a 4th step also. And that is for intractable cancer pain. Next, please. So this is the 4th step of the ladder. It was modified in 2000. The original ladder was in 1986. No? So this was modified in 2000, in which they added the 4th step. And this is for the 10 to 15% of patients who are not responding to step 1, step 2, and step 3 drugs. So what are the interventions that you do for the step 4? You may have to give a nerve block or an epidural injection, or you may have to give patient-controlled analgesia or a neurolytic block, or you may have to implant a device like a spinal cord stimulator or an intrathecal pump, etc. So those are advanced interventions which we are giving to a very small percentage of patients who are not responding to the conventional ladder of step 1, step 2, step 3. Okay. Next, please. So let's discuss step 1 drugs. Okay, next. Like I said, this is used for mild to moderate pain, and the drugs are paracetamol and non-steroidal anti-inflammatory drugs called NSAIDs, and this can be combined with an adjuvant drug. Next. So let us discuss paracetamol, because paracetamol is a very important drug to be used in all kinds of pain, especially cancer pain. Next. Okay. Now, it is also called acetaminophen in the USA, but they are the same drug. Now, it acts by inhibiting the enzyme cyclooxygenase in the central nervous system. Central nervous system is the brain and the spinal cord. Unlike NSAIDs, it has no effect on the peripheral cyclooxygenase enzyme. So its main action is it is antipyretic and analgesic. It does not have any anti-inflammatory properties. So when there is inflammation associated with pain, it is not a very useful drug. Otherwise, it is a very good drug. So what is a dose of paracetamol? See, the dose is up to 3 grams a day, but the daily dose should not exceed 4 grams. It should be always less than 4 grams a day. And one single dose should not exceed 1 gram. So normally we give it as 650 mg. It's available commonly as 650 mg. We can give it every 6 hours because the duration of action is only for 6 hours. Now, it can be a little problematic in patients with liver disease, but even in that, they have found that if you're giving doses of 2 to 3 grams, it is well tolerated even with liver disease. Okay. Pediatric use, very useful. It can be given as 15 mg per kg every 6 hours. And if you can't give it orally, you can even give it rectally, and even intravenous formulations are also available of paracetamol. So it can be given orally, intravenously, and rectally. But in the analgesic ladder, we are using the oral route. Next, please. So what are the advantages of paracetamol? See, I told you it is given at every step of the ladder. So it's a very commonly used drug in cancer pain. The most important feature of paracetamol is it's a very good safety profile. That means the side effects are very, very uncommon. It has, particularly on the gastric mucosa, it does not cause gastritis. It does not have adverse renal effects. It has no effect on platelet function, adverse effect on platelet function. Even it's tolerated by people who are allergic, like those who are allergic to aspirin or those who have bronchial asthma. It is tolerated by those people also. And this is compared to NSAIDs, because NSAIDs has got a lot of side effects. So that is why paracetamol is a superior drug where pain management is concerned. Next, please. But what are the drawbacks? The important drawback is that it has to be given every 6 hours, because the duration of action is only for 6 hours. It has a potential for hepatotoxicity, but so you should restrict at a lower dose, like I said, 2 to 3 grams a day. And if the body weight is less than 50 kilos, then you must reduce it even further. You must give it only up to 2 grams a day. That means only 500 mg 4 times a day. Okay. Next, please. So, like I said, it has a very important role to play in cancer pain because of its safety profile, and because when you're combining it with opioid, you can actually decrease the level of the opioids, like morphine level. Its dose can get decreased if you're giving paracetamol along with morphine. Then it can be given at every step of the ladder. I told you it can be given in step 1, step 2, step 3. So these are all the advantages of paracetamol. Next, please. So the next important step 1 drug is the non-steroidal anti-inflammatory drugs, or called NSAIDs. What are these drugs? I think you're all familiar with Brufen, Voveron, that's diclofenac, naproxen. These are the common aspirin. They are all non-steroidal anti-inflammatory drugs. So it's very common. You can get it over the counter. You don't need a prescription to buy these drugs also. The advantage of NSAIDs over paracetamol is that besides analgesic properties, it has also got anti-inflammatory properties. So when there is inflammation associated with pain, this is a very good drug to give. Okay. Like soft tissue infiltration or bony metastasis or abdominal pain where there is edema, or for even cancer related neuropathic pain where there is inflammation, this drug is very useful, a non-steroidal anti-inflammatory drug. Next, please. Now, I mentioned that paracetamol acts by inhibiting the cyclooxygenase in the central nervous system, whereas NSAIDs inhibits the cyclooxygenase in the periphery. Now, cyclooxygenase is a key enzyme to in the arachidonic acid. I think this may be a little on the side, but just remember there are certain chemical substances called prostaglandins. Okay, and when there is any tissue injury, these prostaglandins are released at the tissues, which is a very important cause of producing the pain. It is a pain producing substance. So NSAIDs act by inhibiting this prostaglandins. Just remember that much. Okay, next, please. Now, the enzyme cyclooxygenase exists in 2 forms. Okay, one is the housekeeping enzyme, which is COX-1. Now, COX-1 is present in the stomach, in the kidney, and it is responsible for maintaining the integrity of the stomach and the kidney and the platelet function. So it protects all this. It protects the stomach, the kidney, and it will also allow the coagulation or the clotting to occur. So that is a COX-1. But there are another cyclooxygenase called COX-2. Now, COX-2 enzyme is the one that is producing the prostaglandins, which is causing the inflammation and pain. So when you want to give an analgesic drug like an NSAIDs, what is happening is you're actually inhibiting the COX-2 enzyme. So when you inhibit this enzyme, prostaglandins is not released and inflammation is opposed. That is, it becomes anti-inflammatory. So just remember that. But besides inhibiting this enzyme, COX-2, because it can also inhibit the COX-1, and that is why you have the adverse effect on the stomach, kidney, and platelets. Because COX-1 has a beneficial effect, but when you give a non-steroidal anti-inflammatory drug, which is non-selective, then along with this, even this is blocked. So you have the adverse effects because this beneficial effect is taken away. Next, please. So now there are two types of NSAIDs. If you have any doubt, please stop and ask me, because this can be a little complicated for you. So if you have any doubt, please put it in the chat box and I will try and answer this. Now, there are two types of non-steroidal anti-inflammatory drugs. The one that we commonly use is the non-selective NSAIDs because it inhibits both COX-1 and COX-2. That means by inhibiting COX-2, it has an anti-inflammatory effect and analgesic effect. But because it inhibits COX-1, it is having an adverse effect on the stomach, kidney, and platelet function. Okay. But there's another category called selective COX-2, which is only inhibiting COX-2. That means the beneficial effect is retained of COX-1 and only the COX-2 is inhibited. So these are the two major types of NSAIDs that are available. Next, please. Now let's discuss the non-selective NSAIDs. The commonly used non-selective NSAIDs are ibuprofen, aspirin, and naproxen. Okay. Now I said it has inhibits both COX-1 and COX-2, and because of inhibiting COX-1, it is causing you GI side effects like bleeding or peptic ulceration. It can cause hypersensitivity and allergic reactions like urticaria, rashes, and bronchial asthma, and it can also have adverse renal effects. But by inhibiting the COX-2 prostaglandins, it has the anti-inflammatory, analgesic, and antipyretic effect. So drugs like Brufen are inhibiting both COX-1 and COX-2. So it is actually a double-edged sword. That means on one side, it has a beneficial effect of decreasing pain, but on the other side, it has adverse effect by causing peptic ulcer, bleeding, and allergy, and kidney side effects, etc. Next, please. So in Brufen, it's given orally in a dose of 400 mg every 6 hours. And naproxen is given around 250 to 500 mg every 12 hours. These are the commonly used NSAIDs that are available in the market. Next, please. Now, just remember, as a result of COX-1, I mentioned that it can have kidney side effects, gastrointestinal side effects, allergic reactions like hypersensitivity reaction, and even effect on the kidney. So this is because of the COX-1 inhibition. Next, please. So who are the patients you have to be careful when you're giving NSAIDs? You have to be careful with people with history of GI toxicity. For example, those who have got peptic ulcers or upper GI bleed, or who are on ecosprin and steroids and all, be careful when you're giving NSAIDs because it can be prone to bleeding in the gut. Then those who have kidney disease, for example, those who have got already a creatinine clearance less than 30 ml per minute, or those who are dehydrated, they are prone to get renal toxicity with NSAIDs. So be careful, advanced stage. Then there are also problems with stroke and MI, which can happen particularly with the COX-2 drugs. And those are the people who have got diabetes or a lipid profile that is deranged, or those who are smokers and hypertension. So again, in that category of patients also, we have to be very careful when you're giving NSAIDs. Next, please. Now coming to the selective COX-2 inhibitors. I told you about selective COX-2 inhibitors, that is inhibiting only COX-2, but is not affecting the COX-1. So the one that is commonly used are etoricoxib, which is called Nucoxia, and diclofenac sodium, which is called Voveron. Okay, these are the ones that are inhibiting only the COX-2 enzymes. So the beneficial effect of COX-1 is retained, but only the pain-producing effects of COX-2 uh, is addressed by this particular drug. Next, please. Now, NSAIDs can also be used topically. It's available as creams and gels, which all of you are familiar with. So it has the same analgesic effect, but there's less risk of toxicity because of these local application. And the ones that are commonly available are ibuprofen, diclofenac, piroxicam, ketoprofen. They are all available as various gels and creams that can be applied locally. Okay, next please. Now, are selective COX-2 inhibitors safe as compared to selective, non-selective ones? Okay, next. See, where the GIT is concerned, it may be safe as compared to the non-selective NSAIDs. That means Voveron and things like etoricoxib will not have much side effects where the stomach is concerned. But where the renal effect is concerned, it is similar to non-selective NSAIDs. On the other hand, it can have a prothrombotic effect and it can cause a risk of myocardial infarction and stroke. So you have to be very careful when you're giving the selective COX-2 inhibitors because there is a risk of MI and stroke in these patients. And even kidney damage can happen. So it is not that safe as compared to non-selective anti-inflammatory drugs. Next, please. Okay, next. So when you're giving NSAIDs, once again, let me talk about the precautions we need to give. First of all, when you're giving it, please give a gastroprotective drug like a proton pump inhibitor, like a pantoprazole, to prevent the acidity problems that happen with these drugs. And we have to be very careful in giving patients with acid peptic disease like gastric ulcer or peptic ulcer. Then ensure that the hydration of the patient is good. And when the patient is dehydrated, avoid giving NSAIDs because they can likely go in for renal failure. When there's a bleeding tendency or if the patient's on anticoagulation, be careful because it has an adverse effect on the platelet function and it can cause bleeding. And then selective COX-2 inhibitors are not to be given in patients with atherosclerotic heart disease or cerebrovascular disease because they can cause MI and stroke. Next, please. So that is all about step 1 drugs. Is that clear? Am I clear? Yes?
Yes, ma'am.
Yes, ma'am.
You have any doubts? You can ask now, otherwise I'll proceed to step 2 drugs. Or we'll discuss in the end. You keep your doubts ready and you can ask me in the end everything. Okay? Now, step 2 drugs. Step 2 drugs, the commonly used drugs are tramadol and tapentadol. So, you using it to treat the moderate pain. You remember I told you step 2 is used to treat moderate pain. So, you can give it along with a non-opioid like a paracetamol, and also you may have to add an adjuvant drug along with the step 2 drugs. So, you may have to give all the 3 also. Now, what is the advantage of the step 2 drug? Now, it's a weak opioid. So because of that, it's not a controlled drug. Controlled drug means there are not too much restrictions where prescribing it and taking it is concerned as compared to morphine. So, and sometimes you can even skip the step also. You can go from step 1 to step 3, even avoid the step totally. Like I said, the commonly used drug is tramadol and tapentadol. Next, please. Now, let's discuss tramadol because that's very commonly used drug. It is a centrally acting drug and it has 2 methods of action. One is it acts as a weak opioid. The second is it is blocking the reuptake of serotonin and norepinephrine, and so it can be given in neuropathic pain. Okay, and less tendency for respiratory depression and addiction as compared to morphine. And yeah, and commonly we can combine tramadol with paracetamol as a step 1 drug. And in fact, you can, the combination is also available like Ultracet, that is a combination of tramadol and paracetamol. Next, please. Now, tramadol has got a very high oral bioavailability. That means if you're giving it orally also, it is very effective. In fact, oral administration is only 1/5 as potent as morphine. That means for if you're giving uh, say morphine 80 mg, that means you have to give only 400 mg of tramadol, that is 1/5 as potent as morphine. Intravenous dose also can be given, and that may be 1/10 as potent as morphine. Okay, and tramadol is available as even sustained release preparations. That means you need to give it only twice a day. So it's called tramadol SR, or extended release tramadol. So that need to be given only twice a day. Otherwise, the duration of action is 4 to 6 hours. Next, please. But it has side effects like nausea, vomiting, dry mouth, constipation, dizziness, sedation. So you have to be explained to the patient that these side effects can happen, and if they do, then you please let us know about it. Next, please. The other drug is tapentadol. Are you all familiar with this drug? Because it's not very commonly used, but this is also a weak opioid. It is very similar to tramadol, except that the side effect profile is a little less as compared to tramadol. But even the dose and the duration of action and also its method of action, everything is very similar to tramadol. But the side effects could be a little lesser than tramadol. Next, please. Now, when you want to combine analgesic drugs, we should not combine two drugs of the same category. For example, you will not combine paracetamol with NSAIDs, right? Or that can be given. Now they are doing that also, but you don't combine a COX-1 and a COX-2 inhibitor, right? So either you give Brufen or you give Nucoxia, but you don't combine the two. Similarly, you don't combine a weak opioid with a strong opioid. Like we don't combine morphine with tramadol. But the ones that are effective are paracetamol with NSAIDs you can give, or paracetamol with NSAIDs with morphine, or paracetamol with tramadol you can give. Okay, so these are the combinations which are tick marked are the good combinations, that which are written into are not to be given. Those combinations are not, there's no rationale in giving it like that. Okay, next please. Now let's come to adjuvant drugs. Next please. Next please. The role of adjuvant drugs. Now, we all know that cancer pain is not necessarily nociceptive. It can be associated with bowel of obstruction pain, bone pain, neuropathic pain. There could be associated symptoms like nausea, vomiting, headache. There could be muscle spasm. So because of all this, next, please. Next. Okay. So because of all that, you may have to add an adjuvant drug to the drug of the WHO ladder. So what are adjuvant drugs? Adjuvant drugs have analgesic properties, but the primary indication is not for pain. For example, you may have giving an antidepressant. Now, antidepressants' main effect is to treat depression, but it has also got analgesic properties. That is why it's called an adjuvant drug. So they're also called co-analgesics because they're giving along with the analgesic of the WHO ladder. Next, please. Now, adjuvant drugs can be broadly classified into specific adjuvant drugs or multi-purpose. Now, specific are given for specific types of pain, like neuropathic pain or bone pain or musculoskeletal pain or bowel obstruction pain. Whereas the multi-purpose drugs can be given for a variety of conditions. So it's not for a specific reason, but you can give it for a number of reasons. Okay, next, please. Now let's discuss neuropathic pain. I mentioned about the types of pain broadly classified as nociceptive and neuropathic. Okay, nociceptive is due to a tissue injury. Neuropathic is because there is a lesion in the peripheral or the central nervous system that is causing the pain. That is a current definition of neuropathic pain. And 40% of cancer patients can have neuropathic pain. So how do you differentiate a neuropathic pain? Because the patient will have a burning pain or a shooting pain or pain on touch or an electric current like pain. So this means that the pain is neuropathic in nature and not nociceptive. Next, please. Now, why does it happen? It's because the nerve is diseased, either because of the cancer or it could be because of the treatment of cancer. When you're giving chemotherapy, it is even affecting the peripheral nerves, and the peripheral nerves are getting damaged. Yes, exactly. They can have a tingling sensation. You're very good, Manisha. Okay, so because the chemotherapy is also damaging the peripheral nerves, so they can have chemotherapy induced peripheral neuropathy, very commonly seen in patients who are getting chemotherapy. It can be because of the radiation induced damage to the nerves, or it can be injury to nerve during surgery. All these conditions can cause a neuropathic pain. So neuropathic pain can be because of the cancer, or it can be because of the treatment of cancer. Next, please. So what are the drugs that are used in neuropathic pain? I told you they're the adjuvant drugs. They are anticonvulsants, antidepressants, the step 2 drugs. Remember, I told you tramadol and tapentadol are also acting for neuropathic pain. And also opioids like methadone, morphine also can be used for neuropathic pain. Next, please. Now, there's a neuropathic analgesic ladder also. Okay, so in that case, in step 1, you start with an antidepressant or an anti-epileptic. In step 2, you have to combine an antidepressant and an anti-epileptic. In step 3, you give an NMDA antagonist. And in step 4, you give lignocaine. Yes, yes. Gabapentin, pregabalin, and amitriptyline. Gabapentin, I'm talking about in my next slides. Next, please. Okay. Now let's discuss anticonvulsants. So this is given when the patient has neuropathic pain, step 1 drug. Okay. And the one that is commonly used, like I said, is gabapentin and pregabalin. Next, please. So what are the advantages? It is good for neuropathic pain. It is very well tolerated. We have to only explain, that you have to be watchful for some dizziness or somnolence, or there can be a little edema. No, these are the side effects of fatigue or weight gain. But if you explain that, it can be given in a very titrated dose. So it is very effective, these drugs, for treating neuropathic pain. Next, please. So gabapentin is relatively less expensive. So when you want to give it for people from a low income, this is a better drug to give. But the dose has to be titrated. Slowly, you have to step over 3-4 days or 1 week, you have to go up to the next dose. So you start with 100 mg or 300 mg and then gradually build it up. Pregabalin is more expensive, and this also can be titrated faster than gabapentin. And this also is quite effective in treating neuropathic pain. Next, please. Now, the other drug of the step 1 drug of the neuropathic pain ladder is the antidepressants. Okay, this is also the first line treatment, and this effect is analgesic effect occurs earlier than the antidepressant effect. See, antidepressant effect occurs at higher doses of the medicine, but at lower doses, these antidepressants are very good analgesics, particularly for neuropathic pain. And because it is also used for depression and anxiety and insomnia, this could be an advantage in treating these cancer patients, because many of them have anxiety and lack of sleep and depression. So they are very good to treat pain as well as this other problems also. Next, please. So what are the commonly used antidepressants in cancer pain? One is amitriptyline, which is a tricyclic antidepressant, or TCA. It's called tryptomer. And the other one is a SNRI, sorry. Please, I'm sorry. This should read SNRI, not SSRI. Okay. I made a mistake here. That's selective serotonin norepinephrine receptor inhibitor. This is a mistake. And the drug that we use is duloxetine. Next, please. But the side effects of these antidepressants are, it can cause sleepiness, drowsiness, mental clouding, even suicidal tendencies. And the other side effects are, next, please. The anticholinergic effect, like they'll complain of dry mouth, and if they have glaucoma, we should avoid it. They can have hypotension on standing, that is called orthostatic hypotension, constipation, urinary retention, and even cardiotoxicity also. So when people have these problems, it's better to avoid this antidepressant. Next, please. So the contraindications are, those who have cardiac conduction defects and arrhythmias and heart failure, you avoid it. Those who have benign prostatic hypertrophy, avoid it because it can cause urinary retention. And those who have glaucoma, avoid. Okay, next please. What are the dose that you give? If you want to give an antidepressant, you can start with dose of 10 mg or 12.5 mg and gradually increase it. Similarly, gabapentin, you start with 100 mg, then 300 mg, and then you can go up gradually to up to 1200 and even 3000 mg per day. Pregabalin, you start at 75 mg and then gradually build up twice daily and then maybe even more. So these are the way in which you have to slowly build up these drugs. And those who are got other comorbidities like who have got hypertension or renal problems, we need to adjust the dose at a much lower dose. Next, please. What are the other drugs? We have discussed the step 1 and step 2 drugs of the neuropathic pain ladder. The next step is, I told you, NMDA antagonist. Okay, so that is, next, please. Okay, now the commonly used NMDA antagonist is ketamine. Now let's discuss ketamine. Next, please. Ketamine is normally an anesthetic. We are giving it for anesthesia, but the dose that is effective for pain is sub-anesthetic dose, means it is very low dose, much lesser than that is producing anesthesia. So it can be given orally, it can be given subcutaneously or intravenously, or it can be given as a burst ketamine also. So these are the various ways in which you can give ketamine. Next, please. But ketamine has got some side effects. It can cause hallucinations, dysphoria. Dysphoria means restlessness. A patient gets very restless. Nausea, vomiting, dizziness. To minimize these side effects, you can add either a haloperidol or a benzodiazepine like midazolam or clonazepam. That will decrease these psychomimetic side effects of ketamine. Next, please. The next step, the fourth step I mentioned in the neuropathic pain ladder is local anesthetics. Local anesthetics like lignocaine is also useful to treat certain types of cancer pain, particularly the neuropathic pain. Next, please. So you have to give it as an infusion of Xylocard over 1 hour, 5 mg per kg. Okay, next, please. It can also be given as a patch. Lignocaine patches are available, in which it's called a 5% patch. You can apply up to 3 patches over the body, and you apply it for 12 hours and then give a rest period of 12 hours. So you apply 12 hours on and 12 hours off. So like that, you can give it for 3 consecutive days and you find that certain types of neuropathic pain are relieved with this topical lignocaine. That is locally applied patch. Next, please. Now, corticosteroids. Like I mentioned, corticosteroid is a multi-purpose analgesics. Now, when I say multi-purpose, it means it can be used for a variety of pains. That means it can be used for neuropathic pain, bone pain, headache because of an intracranial tumor, because of joint pain, because of abdominal pain like a cancer of the abdomen, and also even spinal metastasis it can be given. So that is why it's called a multi-purpose analgesic. Now, it acts by decreasing the edema, by the anti-inflammatory effect, and by its mood elevation properties. Okay, next, please. But it has side effects like immunocompromise, adrenal insufficiency, etc., osteoporosis, myopathy. So that should be kept in mind. Next, please. I'm almost through, another 2-3 minutes. So the commonly used steroids are dexamethasone. Dexamethasone has a very long half-life, up to 36 to 54 hours. So you need to give it only once a day. The other drugs are prednisolone and methylprednisolone. Next, please. So, but remember, steroids can cause insomnia. So most steroids are given in the morning because if you're given at night, the patient may not be able to sleep. And whenever you give steroid, please give a gastroprotective drug like a pantoprazole along with a steroid. Next, please. Now, GABA agonists, they are given for neuropathic pain with their spasticity. So it is used like a muscle relaxing properties. So the one that is given is baclofen in a dose of 10 mg, which we can go up to 200 mg. Next, please. For bone pain, a lot of cancer It may be a primary cancer, but it could be secondary also, like from breast, lungs, prostate, multiple myeloma, colon, kidneys. They go to the bone and they cause a lot of bone pain. So that is treated by using certain medication. Next, please. So how do you treat bone pain? We can start off by giving corticosteroids and NSAIDs, or you can give calcitonin, which improves the prevents bone resorption and improves the osteoblastic activity. Or you can give bisphosphonates, denosumab, and even palliative radiation. If the bone pain or the metastasis is localized to one particular area, you can even radiate that area with these drugs, strontium and samarium. It can cause a decrease in the bone pain. So this is the various ways in which you can treat bone pain. Next, please. The bisphosphonates that we use to treat bone pain are zoledronic acid. Okay, for particularly when there is very severe bone pain, we use this bisphosphonates like zoledronic acid. Next, please. Denosumab is another one that's used for treating bone pain. It also promotes the bone formation and prevents the bone resorption. That is how it is acting. Next, please. And this is the radiation of the bone. For refractory bone pain, you can give radiation to the bony metastasis. For example, metastatic prostatic cancer. Next, please. Okay, pain due to bowel obstruction. That can be very severe pain. So you can start off with steroids. You can give octreotide like atostatin analog, or you can give an anticholinergic drug like hyoscine butyl bromide or glycopyrrolate, or you can combine all of them together to reduce the spasmodic pain due to bowel obstruction. Next, please. The other adjuvant drugs that we are giving are skeletal muscle relaxants, like when there's a lot of muscle spasm, you can give skeletal muscle relaxants like thiocolchicine, tizanidine, chlorzoxazone. Or if the patient is very delirious and hallucinating, you can give neurolepts like olanzapine. Then sometimes you may have to give adjuvants like antibiotics, sedatives, anxiolytics, and laxatives. Okay. Next, please. So in summary, the WHO analgesic ladder is a sheet anchor of cancer pain management. And the advantages are it's simple to use, easy implementation. It can be used even in the remotest corner of the world. And it has legitimized the use of opioids in cancer and non-cancer pain. So that stigma attached to giving opioids is no longer there because of the WHO analgesic ladder. Next, last, finished. That's it. So that is about my presentation. And now, if you have any doubts, please ask. You can either talk or you can put it on the chat or whatever you want to. Don't hesitate. Please ask whatever you want to.
Matthew?
Is it very clear? Everyone understood everything? Acha, buprenorphine patch. Okay. That's a good question. Who asked that question?
Ma'am, Merlin, ma'am.
Merlin. Okay, Merlin. Where are you from?
I'm from CMC Vellore, ma'am.
Okay, very good. Now, buprenorphine patches are also available. Okay. It lasts for 1 week. Okay, the buprenorphine patch. It's called Buvalor patch. It's available as Buvalor patch, and it is giving doses of 2.5 or 5 micrograms per hour. Right now, the duration of action is around for 1 week. When you put a patch, you can put it up to 1 week, but it can be given there's no harm in giving it, like fentanyl patch can be given, buprenorphine patch can be given. Yes, it can be given for cancer pain. And it is available also without too much difficulty, it's available. Yeah. But only thing is, we have, when you give a buprenorphine patch, for the first 1, 2, 3 days, you must give some antiemetic drug because it can cause a little bit of nausea, vomiting. So compared to fentanyl, it's not required, but for buprenorphine, it's recommended that you give an antiemetic for the first 2, 3 days and then give it. But you have to be monitor the patient. That is the only thing, because it's lasting for 1 week. You have to keep a close watch on the patient for any side effects. But it can be given, yeah. Any other questions? Any doubt you please ask, don't hesitate, okay? Any other doubts?
I think no doubts, ma'am.
That means everyone understood everything. Can I ask some questions? Yes? Shiba, is that permitted to ask questions?
One more question is there, ma'am.
Okay, okay. Is the patch fentanyl, I didn't hear it. Can you just show that to me once again? Okay, is this patch fentanyl, bupivacaine? Bupivacaine is not a patch, please. Bupivacaine is a local anesthetic. So patch is only fentanyl and buprenorphine. Okay. So don't write bupivacaine. Bupivacaine is like lignocaine. That's not a patch. Right. So fentanyl patch, can it be used for neonates? No. I don't think for neonates you can use patches at all. Okay. So that is there. The next question, what can be given to a patient who reacts to morphine and pregabalin? Okay. In what way are they, can you come on and talk? That is Mami Aqua. Can you put on your video and ask me the question? Yeah, Mami. Yes.
Hello.
Yes, yes. Tell me.
So we gave the patient morphine.
Mm.
She reacted. We did tramadol. She reacted. We did pregabalin. She reacted.
Okay. In what way did she react?
With the morphine, she had severe itching.
Ah.
And then with the tramadol, there was this out of order. She was speaking irregularly, clear speech, and all.
Okay.
When we gave the tramadol, yes. But with the pregabalin, after she took it, she said she was feeling a bit dizzy, and within a short while, let's say 2 to 5 minutes, she went off.
Okay. So if they're reacting to pregabalin, because pregabalin, the lowest dose is 75 mg. Why don't you try gabapentin? If you want to use a neuropathic drug, then gabapentin at low doses of 100 mg a day can be started, but must give that in the night. You know, all this pregabalin and gabapentin, you must start with night dose because they go to sleep and in the morning they'll feel much better. Avoid giving morning dose for that. Okay. Both pregabalin and gabapentin, you must give it in the night. I tell them to take it at 8 o'clock at night, not at 10 o'clock at night, so that they can sleep off for the next 8 hours. By morning, they won't feel that giddy. So if they are reacting to pregabalin, you try gabapentin at a dose of 100 mg, which is very low dose. Okay.
Okay.
And then if they're reacting to morphine only by itching, you can give an anti-itching medicine rather than stop the morphine, right? Because itching can be treated by giving some medication also along with that. Because itching is a known effect of opioids. So it can be treated by giving an anti-itching drug like a cetirizine or something like that, or an Allegra.
Or
And,
ondansetron, ma'am. Ondansetron is the drug of choice of opioid-induced itching.
Yes, ondansetron. Okay, you can give. But ondansetron is for anti-vomiting, no?
The drug of choice of opioid-induced itching is ondansetron.
Okay, that's something new for
That's-
me, Shiva. I'm glad I heard it from you.
Okay.
Okay, then that's what Shiva says. So you give an antipruritic drug rather than stop the morphine. Morphine should be stopped only for serious side effects like hallucinations or respiratory depression, only then. But for itching and vomiting and constipation, you use a antidote for that. Okay. Okay. Another drug is can be used fentanyl infusion for oncology patients. If they are admitted in the hospital, then you can use the fentanyl infusion. But infusion means you have to give it with a syringe pump. You need all that infrastructure to give infusion. And they have to be under monitoring. When you're giving a fentanyl infusion, you can't leave them in the ward. They have to be on a cardiac monitor. So it's very cumbersome to do that. That is why maybe a patch would be better than giving a fentanyl infusion. Okay. Yes, Merlin. Okay.
Yes, ma'am. Thank you, ma'am.
So instead of an infusion, because they have to be under a monitor in a proper monitored environment, better put a patch on them. That will be better.
Okay, ma'am. Because hematology, we are using continuous infusion, with fentanyl infusion, and the pain was far better for the patients. That's why I asked.
Definitely an infusion will be much better than a patch. There's no doubt about it. But only if they are admitted in the proper setup, you can give that
Setup.
infusion.
Okay, thank you, ma'am.
So good. Some questions have come up. Because when I said I'll ask questions, I think people immediately decided to ask the questions themselves, not.
Can we move on to the case presentation, ma'am?
Yeah.
Okay. So Sister Faustinia, she's a senior nursing officer in Corley teaching hospital, Hana. Faustina, over to you.
Yes, I'm here. So, I'm Faustina Safwa Akofi, a senior nursing officer at the Kolebu Teaching Hospital. I'm presenting on a patient, a male patient who is 46 years old, came with adenomyocytic carcinoma of the salivary gland with possible lung metastasis, and then we queried hypertension. His complaints were jaw swelling for 18 months now. He had severe pains at night, which was a bit piercing in nature, and he had difficulty in eating solid food. He was well until 3 years ago when he developed a submandibular swelling. He reported to the Bator Regional Hospital, which is in Ghana, and was referred to Kolebu Teaching Hospital in the capital for management. But the patient decided not to show up. With him, he claimed it wasn't necessary to come to adhere to the referral. He, however, reported a year after he was referred from the Bator Hospital, came to the Kolebu Teaching Hospital when he noticed that the swelling had increased in size. An incision biopsy was done and samples taken for histopathology. The patient is not able to find the report that was given for the histopathology. He started wound dressing, then defaulted for another 6 months. During that period, he claimed the swelling had gone down, but swelling reoccurred and reported again back to the teaching hospital. He was asked to do various investigations, including a CT scan of the head and neck. On examination, when he came with temperature was 36.6 degrees Celsius, his blood pressure was 140/96. His pulse was 90, respiration rate was 16, his oxygen saturation was 98 in room air, and we stayed him on ECO 1. Generally, his hydration was satisfactory, affable large manipular mass, approximately 10 by 11 centimeters firm. It wasn't non-tender. It was attached to an overlapping skin. Incision scar, which with linear keloid information was overlapping mark. His chest air entry reduced bilateral with no added sound. As I said, the SpO2 was 98. The central nervous system he was orientated to time, place, and hairpin. With his mouth, we saw dental caries, marks extending in the mouth, pushing the tongue to the left. His abdomen was full in the lower abdomen and not tender. His BP, when we rechecked, was 125/85. So that is the investigation. So we could see that where the swelling is. So this is where the swelling is. So we could see the swelling of the, yes. So with the psychosocial aspect, when we did the PT, he said he has no fears, but he wished he was told he had cancer earlier when it was diagnosed. He has no idea about his condition when he came in. He's not with his fashion, he's not able to chat for all preferred meals, eat all preferred meals, sorry, because he can't open his mouth fully and he has pain, and also the pains also interrupt his sleep. His expectation, he wants to be given treatment to make him better. With hope, he said his source of hope is in his junior brother, because he says his junior brother does everything for him, and the junior brother is even to go the length of getting him a treatment if the treatment is available, even if he has to travel outside the country. With the organization, he attends an Assemblies of God church in Ghana here. With his practice, he was not doing anything because he didn't know the extent of his illness. And then with his religion, it doesn't have any effect on the treatment we will give him. So he didn't have any effect. So I did ISAT for him for the 2 visits. When he came on the first visit, we realized that he rated his pain at 10. So he was very, very, very severe. He had a very severe pain. He didn't have any fatigue. He was not nauseous. His depression was there because he claims that we didn't tell him when he started it. He wasn't told he had cancer. So it was when he was told he had cancer. So he felt depressed. He was anxious with the fact that how can I get cancer? And then with everything that was going on, he was feeling he was going to die soon and doesn't know how to go about it. With the feeling of well-being, he scored it 10 because he felt he was not he was not feeling well. With everything that he has come to know, was not the best. So when we gave the treatment and he came on the second visit, we realized that his pain has gone down. It was only depression that was still in existence. So I decided to work on the depression the more this time. With medication, I gave morphine 5 milligram orally for 30 days. We gave the Bitacodel 10 milligram of for another 30 days because Bitacodel, we use it as the anticipatory constipation here. And then with the depression, we give sertraline 50 milligrams daily. With with the first visit, his main concern was that he wanted to get cure for the condition and then to be able to eat solid food. And then when he came for the second visit, he said he has now understood everything we have told him. And so he will come, he wants his symptoms to be managed as and when he has them, and then as and when he comes for review. Examine me. The patient is a 46-year-old man who has the annoyed cystic carcinoma of the salivary gland with possible lung metastasis. He has two children. One, the eldest is 24 years in the University of Ghana. The second, who is a girl, is 17 years in the secondary school. The wife works as a hospital clerk in one of the hospitals in Ghana. His siblings and wife support him with all his medical expenses. He wished to eat some solid food, and so he was referred to see the dietitian on that. And also he wants his pain to be reduced, which was reduced, and also to be able to sleep at night, which he claims is better now. He feels more can be done for him if we should ask around other countries if the mask can be done for him surgically and taken off for him to be able to go back to his work and all. He was extremely thankful because he no longer had the pain he presented with. So I had wanted my colleague and my facilitators to help me with this. When do you think it would be appropriate to consider a feeding gastrostomy tube? Since patients still complain of not being able to eat solid food and all. So I was thinking it will get to a point patients can't feed through the normal way. So we will need to get a gastrostomy tube for him. So when will it be appropriate to do the gastrostomy tube for him? And also, I wanted to find out how do they go about supporting such patients with regards to feeding. And also, I learned that when we do a proper explanation and make the patients understand whatever is going on, and then we are able to allay their anxiety and fears and answer all the questions they ask, that it goes a long way to help them because it gets to a point they appreciate everything we do for them. Thank you.
Thank you, Sister Fasna. Anybody need any more clarification regarding this patient story?
I would like to know, you said that whether we should put in a feeding tube, but at the moment, what is he eating? Is he eating liquid food, or is he eating blended food in a mixie, make it blended and having it? Or and what is his weight? Has he lost weight because of that intake?
Currently, yes, when he came in,
We can't hear you, ma'am. Fastina?
fact that he can blend other food, like let's say rice, mashed yam and stuff, and then take it. But he really wants to eat Ghanaian food like fufu, which have to be swallowed in the ball form and all. But it's a bit difficult for him because it has to be. I asked him to also take fruit in bed.
But has he lost weight because of the intake?
So currently, when he came for the second visit, he's still not lost weight. It was still the 66.
He has not lost weight.
Yes, he's not lost weight currently.
That means whatever the intake is going is sufficient for his nutrition, right?
Yes, yes, yes.
Okay. So in that case, you can ask all the others first, then we will take. Anybody wants to respond to this, the question as to whether he needs a feeding gastrostomy? Would anyone like to give a explanation for that? Yeah. Anyone from the group?
Yeah, Sister Diana? Anybody? Either you can chat or unmute yourself and talk.
Mm, For me,
Ah,
according to me, if for now as we see that the patient did not lose weight and all, so according to me, I feel like we can start when we see that the patient is losing weight and then he is not nourished, uh, yeah, nourished well that time.
thank you. Any other points?
I also think the same, that you have to first counsel the patient, that see, your condition is such that you may not be able to eat hard foods or solid foods, but since you have not lost weight, it will be better that you take orally than putting in a feeding tube. Okay. And he can have the blended food, at least it is going through his mouth to the natural passage. But he'll also have to be counseled that he should not have high expectations that I want to eat my favorite food and crunchy food and all that. No, that has to be counseled to him. And what Shiba, what do you say?
I think we have to find out his insight about his eating, no? So we have to find out the insight about the patient first.
Hmm.
And as Madam said, we can counsel him. And the other thing, instead of the gastrostomy tube, we can suggest rides to feeding if the patient wants. We can go for rides to nasogastric feeding first. Then, if they and the main points, we have to find out whether the patient's health condition is okay for that. So that is the another thing.
Hmm.
So if
So as
we
long as he can tolerate oral feeding with blended food, I think as long as it's possible, that is the best way of doing it.
yes ma'am, yes,
Because he will be more uncomfortable with a nasogastric tube.
yes,
Okay. And then he'll be more miserable with that. So as long, and that he's not lost weight, that means body weight is preserved, his nutrition seems to be adequate. So I think we should continue as long as possible with the oral feeding.
I wanted to find out the option because so let's say in a month's time, in a year's time, and patients can't really feed through the mouth. And then I realized there's weight loss and all. So when will it be appropriate? So should we wait and consider after we realize he can't be fed and then has lost weight and all before we can go for the gastrostomy tube? Because an NG and nasogastric tube can I don't think it will be appropriate for him because the mass is a bit huge.
But is that causing any obstruction? Is the salivary gland swelling? Is it obstructing the passage of food? Does he have
No, not
dysphagia?
yet.
Not yet,
No,
no.
not yet. Yeah.
Okay.
But I was thinking probably he might come up with
But
such.
what treatment is being given to him from the cancer point of view?
When they did when he went there, they said he wasn't responding to the radiotherapy, so they've stopped. And
They're
then
not giving any
surgically,
treatment. They're not giving any
no, they
treatment.
said he wasn't responding.
Okay.
Yes, they said he wasn't responding. And then we went to the surgical team. The surgeon says they can't do anything about it too.
Oh, so that means it is. I mean, it will only progress more and more, right?
Yes.
Okay. So we have to take it at step at a time till he develops dysphagia and unable to eat at all, and then maybe we'll have to consider putting in a nasogastric tube.
Okay.
ma'am.
So I think the second question is also answered. I want my colleagues to help on how they go about supplementing with regards to feeding. Okay, so that has also been answered, I think.
Yes.
Okay. So the only thing is that nutritional intake of what you're giving as blended food should be, have adequate calories and all that, so that his nutrition is maintained, right? So for that,
Okay.
the dietitian will give you a chart as to what should be done, what should be blended. Most things can be blended in the mixie and given by mouth also.
Okay.
Okay, the next question. Shiba, you want to take that on?
Yeah, ma'am. So the last question explained in details all the patients needs to know, allay their anxiety and answer all their questions. It goes a long way them because they begin to appreciate things. Uh, so I think this patient knows the prognosis of the disease. Sister Fastina?
Yes, I'm here.
Yeah, this did he knows the prognosis and diagnosis?
Yes, we've told him, I've told him about it, and then explained to him, and then counseled him and the wife. And then so now they know everything. So we did facts, and then now he knows everything about it. But his worry was he claims a friend a friend has told him when he travels outside the country, probably they can do a surgery and take the mask off for him.
So they both knows the diagnosis. Anything want to add
Rita,
to the
I wanted
groups?
that class, Pallium class. I'll just finish and give you a call.
I would like to hear from the participant side also. So anything you want to add? Anybody? Uh, Sister Faustina, what about his children's?
The the eldest who is in the university knows about it, but the other one, the second child, is currently not staying with him. He's staying with his big sister outside Accra. So she hasn't really come home to see his father, but the father also hasn't told him about it. But the son knows about it.
So, did they know his condition? The children's?
Yes, they know.
They know. Okay, it's good.
But it's only the second child, the father is not ready to tell him her because he's a bit closer to the daughter. He doesn't want, and the daughter has an upcoming exam. So after the exam, he probably will tell her about it. But the son knows.
Okay, thank you. Madam, you want to add anything?
Yeah, what I want to say is, I think, Faustina, you're managing the patient very well, because when you see all the scoring as compared to in 1 month's time, most of it has been controlled, his depression, his pain and everything. Only the anxiety element is left, right? Huh?
Yes.
Otherwise, his pain is well controlled and his sleep is all those parameters have really settled down, which is very good. That means your management is good. Where anxiety is concerned, although you're giving that anti-anxiety medicine, he's still having a high anxiety score. So now I feel a lot of psychological counseling is also very important to allay his anxiety.
Okay.
Okay, so anxiety can be treated by medical means, by pharmacological drugs like sertraline, like you're giving, and it can also be non-pharmacological methods like psychotherapy. Okay. And for psychotherapy, it's not necessary to have a clinical psychologist to do it. Even you can do it. Okay. You just have to sit and talk to them and explain to them and, see how anxious they are and try to address all their fears. Okay. And maybe if he has got unfulfilled wishes, it has to be done. All that will allay his anxiety to a certain extent. It looks like he's a very religious person also, right? He's attending one church called Assembly of Gods. So that means he's a religious person. Maybe the pastor of the church or one of the congregation members can come and speak to him also. Okay.
Okay.
But his
Okay.
main problem is his anxiety should be allayed. And that, besides medicines, you can even do it by counseling or psychotherapy. Okay. So that should be taken care of. Possibly from the religious point of view, or even as a nurse, you can counsel him. All of us, being palliative care people and pain doctors, we are all unofficially even psychologists also. Okay. I counsel my patients. I'm not a qualified clinical psychologist, but by talking to them and letting them take out all their fears, by venting all their emotions, you are actually providing relief for them. So as all of us need to learn this art of listening to the people, talking to them, and unofficially trying to comfort them and give them, uh, soothing advice, and even things like, in the family matters, you can discuss with them, are there any unfulfilled wishes which he like to do, you know or maybe he wants to make friends with someone whom he's not talked to for some time. So there's so many things can be done by which he will also have some peace. It can be done spiritually, it can be done by you also. So anxiety element needs to be addressed, I feel, in this person, because nothing much can be done from the treatment point of view. Also nothing is being done, and his pain is decreased, his depression is decreased, but the anxiety part has to be taken care of.
Thank you.
I'm sure as nurses, all of us are, our job is not just to give medications and take care of the physical needs. Remember, all cancer patients, you have to do what is called a total pain management, not just a physical aspect. That is only one part of the problem, but they will have social, psychological, and spiritual and financial problems also. So that also needs to be addressed. And as all nurses and doctors, we need to look at that part of it also and try to treat not just the physical aspect, but we have to treat the person as a whole, not the disease, but the whole person, right?
Yes, ma'am.
Thank you, ma'am.
Anything else, Shiva?
No, ma'am. I think we can wind up the session. So we have learned many things today from Mary ma'am. Madam did a detailed presentation. We have learned the steps of managing the WHO analgesic ladder. So we are not our nurses. We are not an authorized person to for prescribing the drugs, but after they prescribe the medication, we are the person to carry out that administer the drugs to the patient. It's our role is to find out the reassess the patient's problems. So that is very, very important from our side. So every time we usually the nurses are more time spent with the patient. So our role is to find out whether the problem is the problem is reduced, that pain is reduced or not. So if the pain is not controlled, so we can inform the doctor, and maybe we can give some another drugs. So that important points we need to learn here is don't assume. So we always we believe the patient's words. So every assessments, sometimes the patients, the nurses, usually we assume, so whether they have pain or not, something like that. So I definitely my experience from palliative care, also important learning points in palliative care in my journey is believe the patient. So we usually, the nurses don't believe the patient words sometimes. So that's very important to believe the patient words. Pain is the second definition of pain is what the patients hurts. So that is the important points. So thank you, ma'am, the detailed presentation. So we have learned a lot from you. Thank you, and thank you, Sister Faustina, for the that good presentation. Okay, thank you all.